I am a mom of two boys, and this is, I guess, a recent picture, and I'll just make this into a little slideshow here, I guess. So I have two sons. Jax is the older one, and let's hope this works. And then Jude is the younger one with the cute little bow tie there. And so they're 10 and 8. And let's see, I grew up in a small town in Ephrata, Washington. Sounds like we have somebody here that is, an Ephrata Tiger alum as well. And so I did graduate from WSU in 2007, actually with a degree in interior design. And so it's kind of a funny question as to, so why am I here talking to pharmacy students? So how does an interior designer get asked that? So, and as Madison said, I just have kind of an interesting story. And so here's my college graduation picture. I actually did not want to walk at graduation, but I don't know, pharmacy school, I don't know as much about, but we had 40 students apply to design school, and only 12 of us were accepted in and walked. And so I had a lot of peer pressure, as we're such a small class, that I had to walk with my classmates. And this guy here is my husband, Jonathan. And we ended up, I guess, 3 years after graduation, we had two kids, or I had my first son. And so this was us when they were 2 and 4 years old. And this was taken right as Jonathan was being diagnosed with cancer. And so that's kind of where our story took a little bit of a turn, but yes, like I have to show this picture because we definitely are Cougs and raising our children right for a love of Cougar football. Not sure if you guys watched the football game on Friday, but that freshman quarterback seems to have some real potential. So that's a little bit about us, but I can stop sharing a little bit just so that you can see me, I guess, but why am I here and chatting about this, and what brought me, an interior designer, into the oncology sector and passing legislation and getting into medication donation? And so, yes, as Madison said, Jonathan at the age of 29 was diagnosed with a cancer called osteosarcoma, and he was a healthy young guy, and we, after graduating from college, stayed in Spokane, and he went into banking and I went into residential construction. And so we're just kind of like living the American dream, if you will, happy kids and working. And then all of a sudden life changes. There was nothing really serious really that started. He just started having knee pain. And then he went to the doctor eventually to have it checked out. And that turned into, MRIs, referrals to orthopedic oncologists and that sort of thing. So, when you're going through chemo, and our cancer that he was diagnosed with, we did not have the luxury of doing outpatient chemotherapy. So when he got sick, we had to basically live in the hospital. So we would be 4 or 5 days in the hospital, 4 or 5 days out of the hospital. And then we had 2 young children. And so this was awful, and obviously. And so basically Jonathan had to go on disability. He couldn't work. And so he started to struggle with depression, and what is his purpose? What is the purpose of all of this? And just the day in and day out of going through cancer and prognosis and all of that. And so something that he really, wanted to do for his own health and for others, he had decided, I should really look into helping other people, and I will get joy out of helping others. And so that was his intention. And so we started doing a lot of research, and in the greater Spokane area, there was not really a lot of nonprofits that were serving adult oncology, actually really none, that were like strictly adult. And so we also learned that about 80% of funds raised that go into the nonprofit sector of oncology go to childhood cancer. yet only 1 in 113 people diagnosed with cancer is a child. So you see this like huge discrepancy in support and resources for people battling cancer, mostly go to children, but adults really don't have a whole lot of resources. And so he was very intentional about focusing on adult oncology. And so after we formed that nonprofit and started raising funds, we were really beginning to look at who can we help and what do we serve. And so in that process, we had a circumstance ourselves where we had medication that, and as I'm talking to pharmacists, I'm not sure like good or bad to start listing drug names specifically, pharmacy students, I guess. He was taking a medication that after you do chemo, it wipes out all of your white blood cells. And so they give you a shot to reproduce white blood cells and boost your immune system back up. And so he was on what the doctor wanted him to be on as the most effective drug that had the least amount of side effects. And so what ended up happening was a new year came around, his insurance changed, and you guys will learn this as you get into the world of pharmacy. And I don't know how much they teach you about this at school, but insurance companies really determine way more than they should. A doctor can tell you this is what medication you should be on, and an insurance company can come back and say, well, this is the cheaper medication and does the same thing, so we're only going to pay for this. And so that was exactly our circumstance. And so his medication had to change to something that was cheaper, but didn't work as effectively and had some additional side effects. Well, they dispensed all of these injectables to him for a few chemo rounds. And even then, even though it's cheaper, it still was not cheap. We're talking still like $8,000 a dose, And so in the oncology world for medications, oncology specific meds, I think right now are at an average of about $10,000, like for a prescription. So oncology meds are extremely expensive in the world of medications. And so we changed meds. He ended up having a reaction to this med and got very sick. And so the doctor fought, and we went against the insurance company and had the medication changed back to the original one. However, we had all of these leftover meds that were very expensive. And so we tried to bring them back to the pharmacy, and they told us they could not take them back. And so here is this idea, right? Where we lived through this experience where we know we're doing chemo next to families where they're foreclosing on their home, they're fighting with paying their bills and feeding kids, all kinds of things. And even now that I am more involved in cancercan't, I really am seeing the financial ramifications for cancer families. And so it just seems so wrong where there are people fighting to pay for medications, can't afford things, and we're throwing away, about $30,000 worth of meds because they can't take it back. So that was when we really looked into this medication idea of medication donation and repository. And I reached out to a friend that was an attorney and just kind of asked, hey, here's an idea. Is this crazy? And so we began the research process, and there are other states, and I'll kind of talk a lot more about that, that have medication repository systems, but they're all very different. And so essentially, we began the process of passing legislation to create a medication repository. And so I have a little video actually that after creating this, I made this video with Manpreet and another board member and myself, and it kind of goes over the problem that we look at in our country and just kind of what patients face and physicians and pharmacists. And so I am going to share this video with you so that you guys can just kind of, I think it explains it better than just me like talking about it a little bit. So let's see here if I can get to it. So, okay, let's hope this works because I haven't played a video through Zoom. So let me know if you guys can't hear it. Are we good? My name is Becky Van Keulen, and I am the executive director of the Charitable Pharmacy Group.
My name is Manpreet Chahal. I'm a pharmacist at Summit Cancer Centers. I'm the president for our Charitable Pharmacy Group.
My name is Jonathan Staben. I'm a family medicine physician for Rockwood Clinic, and I am on the board of directors for the Charitable Pharmacy Group.
We were started by a group of individuals who saw a problem in our community and wanted to try to solve it.
I learned about this program a few years ago from Jonathan and Becky Van Keulen, who had the idea for patients to be able to
Give back medication that they had left over that was no longer needed.
In 2015, when my husband was battling cancer, we had a situation where he had a reaction to a medication and we had to return it back to the pharmacy, or thought that we should because it was very expensive. We were told that you have to throw it away, that it is illegal for a pharmacist to redistribute a medication that has already been prescribed to another patient. Jonathan and I just thought that that was so wrong, because here we are, in the hospital every day almost with patients who were talking about choosing to take those medications or feed their family or dealing with bankruptcy.
The cost of medications is a huge issue. Every doctor, every pharmacist, every patient, every caretaker is affected by this.
A common scenario I have is that I'll have an elderly patient and they're on limited income, they're retired. I'll prescribe a medication and they'll have an out-of-pocket cost of a few $100s. These patients, they have to choose between being able to breathe or get their blood sugars down and being able to pay their rent or other basic bills.
I can see it in their eyes, having to choose between treatment or having to choose between being able to keep their house.
This is a huge problem in our country. Currently, the statistic that we're reading is about 5. Oh no. Let's see if we can. Uh-oh. Sorry, guys. Maybe I'll get it to come back here so I can try to refresh or something. But I can go back to this really quick and just kind of say that this is a photograph of the day that this was signed into law, the legislation that we passed. And so Governor Inslee, and then this is Kevin Parker here, who is the state representative that we worked with to pass the legislation, and he is a Spokane representative here. And then this is Matt Helder, who was the legislative assistant that I actually worked with to write the legislation. And then this gal here is Mary Helder, and she was a lobbyist and an advocate for the American Cancer Society, actually, and she jumped on board and partnered with us. And so along with like Manpreet and some like other attorneys and physicians or whatever, we did a lot of research and wrote legislation to create the Washington State's first medication repository system. And so this picture is kind of funny to me because I don't know, you guys might laugh at this or not. So there's these two other people here. None of us have any idea who they are. So in this legislative photo, we were photobombed by these two people that we don't even know. So kind of a funny thing, but I will try or attempt to just like re-get this video to load here. I'm gonna have to like minimize this to see if I can, and then try to catch it back up if it will work. And if not, I'll just give up. But sorry, the video's like, okay, so I'll just give up on it. But let's see here. So basically, that the day, actually 1 week after this legislation was signed into law, Jonathan actually ended up passing away. And so what I've kind of done is taken this very personally in that this is something that in effect can save people's lives. And so we started this together. And so this is just very personal to me as something that we can do to help others. And so through all of this research and passing the legislation, and because not a lot of states have legislation that are like Washington State's, I have pseudo become someone that that other states are looking to for consultation and looking about this in a discussion of national repository, which is how I got asked to speak at NCODA. And so they've reached out to me, and actually even since speaking at the Fall Summit in 2019, I have presented to the NCODA board a couple of times about this idea of a national medication repository. And so this is a problem, and like I said in the video, this is a problem throughout our entire country. And so I thought that maybe what I would do is a little bit and go through kind of the legislation so that you guys really understand how it's written and how it works, because and I'm not sure exactly, you know, the message that's being taught in pharmacy school, but the pharmacists that I've worked with thus far have kind of told me what we're doing. We're kind of like the black sheep of pharmacy because this is like the #1 rule breaker. As soon as a medication leaves the pharmacy, you can't take it back. It's, you know, like listed as not safe. You can't prove the efficacy or anything like that. And so, you know, there's actually movies that have been made about this idea of medications on the black market. And so, you know, like, so I don't know, guys, go look this up, you know, like it's actually an interesting concept, but it has been a huge no-no. And so what we're doing is kind of, you know, our attorney has really compared it to marijuana laws, where state by state, they're legalizing marijuana, but it is not federally legal yet. And so we're kind of looking at this similarly as we get more and more states to pass similar legislation, or as we read their laws, you know, like, is it possible for states to share donated medication and inventory and give them to patients in need? So that's really what I'm doing now, and like looking at this. And so I will try to share my screen again, and we'll go back into kind of looking at more of this, the idea around medication repository. And let's see here if I can, okay. So this is basically the, I guess the slideshow that I kind of went through with NCODA. And so when you're looking at developing a medication donation program, there's a lot of things that have to be considered. And so you first have to look at who can donate the medication. And so we're kind of using Washington State as a template here in terms of what, you know, what is Washington doing and what are, you know, what are other states doing. So that's kind of the comparison that I'm going to make here, because the way we've written our legislation is one of the most, I want to say, liberal legislations in comparison to a lot of other states. And so you got to look at who can donate, what can be donated, where can you donate the meds, who can receive the meds. You also have to consider things like liability and who's going to pay for such a program. So, so these are all things to consider when looking at this. So, okay, so medication donation in the United States. Here is a map that was created by a university that's kind of been studying this idea of medication repository. And this is what they say are the states that have legislation around medication repository. So the idea of giving medications back and reusing the meds. And I argue with this map because I think it's completely inaccurate in that I think that certain states may have operational programs, but who they serve is not really who we're looking, you know, there's a lot of different boxes that we have to consider when you're looking at all of those parameters of writing legislation. And so, so anyway, so this is kind of the map where they say there is some sort of medication repository. So if anybody goes into pharmacy in any one of these states, you might want to look up what the legislation is when you get there. But so we're going to look at this in 3 models in answering these questions. And so first I want to look at who can donate a medication. And so from that map, you'll remember that California was a state that had an operational medication program. And so their legislation was written in 2012 and said that skilled nursing facilities, acute care hospitals, psychiatric hospitals, the correctional treatment center, elderly care facilities can all donate medications. So there is like an asterisk here, because specifically in their legislation, it says that drugs received, they have to make sure that they have not been in possession of any individual member of the public. So it has to come from some sort of facility. And as you start looking at a lot of these states and their legislation as having a repository program, what you'll find is many of these states are actually only operating a repository program within the correctional treatment facilities. So jails essentially, they're trying to save themselves money by recycling drugs in a correctional treatment center, and they're counting that as a drug repository program, which it is, but it is not serving the general public. So so those are reasons why I look at that map and I kind of poo-poo it, because I don't think that that's necessarily the intention of what you should be looking at here. So the next model, so like model 1, you have California that we're looking at. So only facilities can donate the meds. Now in model 2, we're going to look at 2 other states, which is Colorado and Florida. And their legislation is written that it says, like Colorado is charitable clinic, pharmacy, physician, but most importantly here is a patient or a patient's family. And then in Florida, it says a person. So essentially their legislation is much more broad, that anyone can donate to a program. It's not just a controlled facility. In the second or the third group that we're looking at here is model 3, we'll look at Iowa and Washington. So I'm going to keep these kind of groups together so you can look at the 3 types of programs that we have. And so Iowa is also very liberal in their terms. Like, so California is pretty restricted. Model 2 is a little bit more open. Anyone can donate. And same here. So any person, or our legislation is written, any patient or patient's representative. And so this is really interesting because we brought in this idea of patient representative. So consider this now. For years, if someone passes away and their spouse now is in possession of their medication, for years that has been illegal. And so oftentimes if you're in possession of someone's prescription medications, you're breaking the law, right? Well, now if in Washington, if you are in possession of someone else's medications with intent to donate those medications, acting as a patient's representative, you can do that. So now we're allowing a family member or anyone else to donate meds because this is addressing things like when patients pass away. Even here, I've been working with our local police department, because you have instances where a patient dies. If they die in their home, the police respond, the coroner, and one of the very first things they do is take all of those person's medications and take them to the incinerator. And so we're even working with the police department to identify, can some of these medications be donated? And it is now not illegal for that spouse to be in possession of those medications because they can donate them. So, so it's kind of an interesting thing. So again, that's why Washington is becoming more liberal. So, okay, so we have, a little in a box, a little bit more liberal with both these models. Now we need to look at who can receive medications. So in California, where only a more restricted area could donate, the people that can receive the meds are medically indigent persons, like free of charge. So basically you have to be uninsured, like those without public or private health coverage they cannot afford to pay for their own medications. So that is the only people that can receive donated meds. Then if you move to the second model in Colorado and Florida, they have uninsured or underinsured patients. And this term underinsured was something that we duplicated because this will be something that you guys will deal with regularly in the pharmacy. Like, so basically what this is, and like, let me know if I'm over defining things or situations or scenarios that you guys will end up dealing with as students, which is, we saw an interesting change in healthcare when Obamacare passed, in that you have people that don't have health insurance. Many pharmaceutical companies have grant programs for these patients. If they have no insurance, they qualify for free drug, and there's all kinds of programs for them. Well, then all of a sudden, so many people were kind of told that they have to then go get health insurance. You can't really be uninsured anymore. So many people were purchasing plans that were like catastrophic medical insurance and had very high deductibles and very high copays. And so what ended up happening was, when the catastrophic life event happened, like cancer, and your medication cost is $10,000, and you have a max out of pocket of, $10,000, $15,000 with a 20% copay, you tell me how a middle income, family that's making, $40,000, $50,000 can afford to pay $2,000 or $3,000 for one prescription. So this is the people that we're trying to say are underinsured, and they should still qualify for programs like this, because even though they have insurance, it is putting them in a very hard position to even be able to afford it. So the pharmaceutical companies, they don't qualify for free drug now because they are insured, but they can't pay for it. So underinsured is also a new term that's interesting. So Florida is much more broad, that it just said residents can receive it. So that's interesting, and something when you're looking at a national repository system, that necessarily means we may not be able to share drugs with Florida the way the way this is written, because it has to stay within Florida residents. But again, like, except those that are Medicaid eligible, and so they have their own kind of restrictions on this. But okay, so then you go into the third model of who can receive, and we look at Iowa and Washington. So Iowa has theirs say that you have to be an Iowan. So that's, again, something for a national repository that we are looking at. But additionally, that you have to be below the 200% of federal poverty level. So you have to be very low income. And so then it also says uninsured or underinsured individuals, and then also medical facilities can also use that. So we wrote our legislation to just say any individual, and we were extremely broad that anyone can access this program. However, we did address that priority must be given to those that are uninsured. So we were much more broad. In the last kind of consideration to look at this, so now you have, again, our three models that we're looking at, where it's kind of restricted about who can donate. There's kind of some restrictions about who can receive. In model 2, it's more broad about who can donate, but it is a little bit more restricted about who can receive. And then in the third model, particularly Washington, we are very broad about who can donate, very broad about who can receive, but then we also need to look at what specifically can be donated. So here's where California in that first model opens up. They are much more broad in what can be donated. So you're looking at medications that are unopened and in tamper-evident packaging. In the second model, Colorado and Florida, this is something that becomes interesting, is now this program is strictly made for oncology. So only cancer drugs are things that you can really even be donating. And then again, unopened and sealed. So where they were much more liberal about who can be donating and maybe some about who can be receiving, they're limiting themselves to what types of medications can really be donated. And so then in our model, in the third model, Iowa and Washington is also much more broad about what can be donated. So prescription drug supplies, and it has to be unopened and sealed. And we have, in all of these cases, anything that is a drug that goes through the DEA or narcotics that you track these, we don't really want anything to do with them. And so narcotic medications are excluded from almost, well, I think every program that I've researched in every state. So that's just kind of a hard, fast rule. We don't even want to deal with narcotic meds. But it is kind of, it is very important here because ultimately patient safety is the number one concern. And so in the legislation, we have rules about, that's where things come in about who can receive these meds, who is inspecting them to make sure that they've not been tampered with, that sort of stuff. And so our legislation is written that it has to be returned to a pharmacy, and the pharmacist has to inspect the medications. And then even then, you're writing additional language in the legislation to protect the pharmacists themselves, to protect physicians, and essentially putting all of the onus or liability that the person that then is going to get the drug and is going to take the donated medication, they're saying, I realize that, maybe I can't afford this med or whatever, and I'm taking on the responsibility to say, I know I'm taking a donated med, and I release liability from anyone else that has been involved in this process to help me access it. Because in many cases, otherwise, they wouldn't even be able to have the medication, or they couldn't get it, or they couldn't afford it. So, so that, that's kind of the big question. So again, I guess that's kind of the end of, in a quick synopsis, I don't know how long that took me to get through there, but that's kind of the program. And then, what kind of questions anybody would have, and if you want to chat about this more on a national scale or what we're doing with that. But the kind of what the end of the video talks about that I didn't really share a lot, and for you guys as pharmacy students that are going out into this industry, we have created now also a database and a website, and we're working on getting this up and going, that donatedrugs.com, if you go check it out, that we have automated the Department of Health form that you can fill out the Department of Health form, tell us what you're donating and where you're going to donate it, and then to take some time off of the pharmacist that would be inspecting the medication. They can just, it's already all input, they verify the information, then accept or reject the drug, and then it auto-populates the system where then the general public can search our inventory of what we actually have. And so no other states are doing this. This is kind of like a, we know they're trying. So Tennessee has consulted with us about what we're doing with that. And this is where the idea becomes possible with technology to create some sort of a national repository. If we can share inventory live, who has what, and you can fill prescriptions by mail, this starts opening up this idea. And we're doing this already in Washington. Actually, just last week, I was on the phone with a gentleman from Central Washington who found the medication on our database that we had that was going to cost him $4,000 to have this med. We had it and we mailed it to him. And so he got that med for free. And he just searched it up in his oncology with his doc, right there. And so this is working. But there are a lot of complications in looking at this nationally when you would be mailing drugs across state lines, that this might not be legal. And so some of the attorneys are sitting here doing the la, 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 like what's legal and not. But some of this takes a lot of time because it's groundbreaking. There are no there are no laws around this. And we're, just creating our database, it took us 6 months around HIPAA, figuring out rules with this sort of thing. So lots of questions, like lots of things that we could go into, but not to just talk forever. If anybody has any questions or interest.
Becky, I had a quick question actually. So as you were going through the presentation, I was wondering, how would we as students or even as like future pharmacists and healthcare providers, how do we get involved in the type of work that you're doing? And is there any ways to like specifically get involved with your nonprofit as a student and try to help with the matter?
Yeah, actually. So as students currently, actually the pharmacy that we've partnered with here has multiple branches. And I actually just sent the owner of the pharmacy a question just kind of about what can we do to make sure inventory is matching our database correctly? You know, like that is kind of seeming to be, because this it's fairly new, to be honest. The database was launched 4 months ago, where you can search things live, and feel free to go click around that. But the idea around comparing our database to what is in the actual inventory, I am trying to get the ability to have pharmacy students be able to go in and just match those to make sure. And so like you could volunteer, you know, once a week or something like that, and go into the pharmacy and essentially keep our database up to date and accurate. So people that are searching for meds are not, you know, not getting false information unintentionally. So that's one thing to kind of volunteer with us. But I think as you more so enter into the workforce, eventually, once you get out of school, is really advocating for such a program. Eventually, as we grow, we will have more pharmacies that we need to be on board, to be participating pharmacies, to accept the meds and be redispensing them. And so I think really just understanding that this program exists, and really we have this huge, you know, issue in front of us, and that we have to retrain the public in that stop throwing your drugs away, quit dumping them down the toilet. You know, like there are other options and people can use these medications. And so even just like the public service announcement, if you will, and just spreading the word and letting people know that this exists is huge. Does that answer your question?
Yeah, no, that's super helpful. Thank you so much.
I have a question for you now.
Yeah.
So you mentioned our state, Washington State, being very liberal or relaxed, having like a broad scope on who can donate and what they can donate and who can receive. And I'm wondering, has that caused any sort of legislation problems, or I don't know, I'm thinking like lawsuits because it is so liberal. I was wondering if you had any answer.
No, not, so we've kind of been strategic in that, so once you pass legislation, and this is just like, this is going from pharmacy into like law school, if you kind of will. And I, as an interior designer, sit back and you have to surround yourself with intelligent people around you, because that's really the only way I've been able to successfully do this. But once you pass a law, you promulgate rules, essentially. So it goes from legislation to the people that produce the rules around how it actually works. And so once the law passed, were very quiet and really didn't do much with the program. And that was intentional. And we have not been very public to go out and be advertising that this exists and all of that. And so that's been intentional. And the reason for that is, if you stay quiet, lots of laws get passed that people do nothing with it. Nothing happens. And so rules are not formed around what you're doing. And so for us, we skated under the radar, because that's why Washington on that map shows like there's no program, because we've been operating simply in Eastern Washington within oncology practices and, you know, a locally owned pharmacy under a pilot program where we're just kind of recording our own data, proving, you know, like just through word of mouth and in like these practices, this is how much in value of meds we've been able to have donated and how much has gone back out to the patient. So those are all things that we've kind of been quiet about it. And so nothing, you know, like nothing has happened in that way. And we wrote the legislation so tightly that liability, we've really protected everybody as best we could. And so, so that's kind of, I think also how it is written is very important. We very much address liability.
It's very interesting that you say you've kind of kept it on the DL. It's kind of like the opposite of a typical business model, perhaps, would do it. Yeah.
Yeah, and that's intentional around the rules, so that they haven't really formulated a lot of rules about how we have to operate, so that we can be more liberal with it. And there's also the supply and demand, right? So we can't just go public and tell everyone, or haven't been for the last few years, to say this program exists, go get free drug. Well, we have to have the drugs that have been donated to give away free drugs, right? So we've had to be very intentional about how you create the program, how you're targeting people to donate before you're really telling them that it's available. And so there has been a lot of business planning, and just how do you roll this out so that it doesn't grow so fast that it fails, if that makes sense.
Yeah, that's interesting. Thank you. Does anyone else have any questions that you'd like to?
So I just mentioned, Becky, my husband actually went through cancer, and thankfully was cancer free just before I found out your husband was diagnosed. Watching Chelsea's page and kind of seeing you go through that process was really tough for me. I got really lucky, and I think those post chemo shots, I think I had 2 extra. And I know that we were one of the lucky ones that were able to figure out that dosing just right by the end, we didn't end up with as much waste as some people do, but really seeing that, I saw it more with the antibiotics at the front end, because my husband they told him for 6 months he had an infection due to obesity, and it turned out it was cancer the whole time. And I had boxes of antibiotics that we'd get through halfway through a dose, even just a 7-day regimen, and they'd change something on us. So seeing you start this program and going forward and taking that initiative to help other people, I just thought that was really incredible, and to move forward. And so from my perspective, I really appreciate that as a family that has gone through cancer, know the cost of some of these chemo drugs, and know that there is so much waste. I was thankful KBH here in Ellensburg, we were in the hospital 3 different times, and they allowed us to bring in our prescriptions for the shots, for his pain care medications, to save us and the pharmacy money in trying to get, 3 days dosage of a medication that costs $50 for 1 pill. So just seeing that, and kind of that movement of, helping people out with this has been really incredible. So I really appreciate your moving forward with this and all of that you've done.
Yeah, thank you. Thank you very much. Yeah, and you brought up some things that were kind of interesting, because, one of the downsides of, as we're looking at the program, of like medications that are sealed, where you're saying, we've went through half a dose, we went through, 4 days of a 7-day prescription. So one of the things that we really have to look at is it has to be sealed and tamper proof. So these amber bottles that most people are getting, that are like filled with pills or have so many doses, those cannot be returned. And so, because you can't prove the efficacy of it, right? So if we can start moving towards blister packs, where we can take back a blister pack that, there have been 3 pills popped out of it, but 4 are left, we can prove that those other 4 pills are sealed. And so those are things that, and even this is outside of my realm, you guys probably know more than I do, but I think that pharmacies also have things where they can pre-package pills for, like each day, and there's equipment that like seals pills, and, so moving towards things like that as you're dispensing, those are ways that we can prove that the medication is sealed and have not been tampered with. And so you bring up an interesting point, is like that happens all the time, that there are half-used prescriptions because something changes. And so what do we do with these rogue like 2 or 3 pills? Well, if we can keep them sealed in some way, that's how we can use them. And so that's something that we have to address eventually, so that we can start capturing more donations.
Yeah, and a lot of it on a personal level for that with us is that we did a lot of recycling of antibiotics. And we just played this game of like, oh, let's put you back on this one. So our pharmacist was really great and was like, okay, you only did like 4 days of this one. Do you still have that left? And so really watching how much medication I had on hand. And if we were restarting it, I would start with the old stuff and then only take a partial supply to get through, or wait and see if they change their mind again. It was a really tough thing to watch, but that's how I chose the route for pharmacy. You went the other way and started becoming an advocate for patients. And
yeah, I mean, you guys, medication waste is a huge problem. And this is also something that is very under-researched. So like even when I went to go speak for NCODA, I set out to really try to find actual data, but there's like almost no way to study this, because how do we really quantify how many pills someone is flushing down the toilet? And they're not going to report that. So we're estimating from lots of different studies and things like that, is they can say about $5 billion a year are unopened, unexpired meds that are being wasted, that are being trashed in some form. And so like, that's insane. And so, but I mean, like, so, and NCODA's really tried to take on, so Mike Reff has really worked on trying to, have pharmacies track waste as best they can, because this is an understudied topic and we really don't have a whole lot of information on it. But what we do know is there is a lot of waste, and but putting an actual number on it is really just an estimate.
More to the add on that, I did actually a lot of the bubble packing. It's interesting you're saying that for waste, because I bubble packed medication for nursing homes, and every single day we'll get medications back in bubble packs that we specifically package for each patient. And maybe one bubble pack, I don't know the specific name for each little puncture in the pack, but the whole pack you'd have to put in the concrete mix to dispose of medications. And in undergrad, I was thinking, this is a huge waste, but I didn't think about how much of a waste this is. It's ridiculous.
Yes. Yeah.
Especially for nursing homes where, it's the last stage of life, and, there's very, very rare situations where they pass away on the last day of their medication.
Yeah, no.
Very rare.
Yeah, no, those are the exact instances that I'm kind of referring to, that if there's some way, and this is where I said, I'm a designer, I'm not a pharmacist. So like however you guys are packing these pills in blister packs or whatever, whatever, can we be doing individual pills, and you just have all these packs that go to the patient instead of one that has multiple pills? Because then when they come back, can you keep 4 of the 5 pills that, or something like that? And then within that same facility, you can reuse the meds, because you as a pharmacist are accepting the med back and inspecting it. And so, and then you can kind of just, so a lot of other states, that is really how they're doing it, is they're kind of operating their own program within a lot of these facilities. And so they're reusing drugs in nursing home facilities, where we're trying to take this into a larger scale to really help those in the general public as well. So yes, like you're spot on with exactly what I was referring to. Yeah.
Does anyone else have any other questions before we end our meeting? Okay, so So with that being said, I just want to thank you so much, Becky, for taking the time out of your day to speak with us today. And we really appreciate, especially as students, your personal testimony about your journey with cancer and whatnot, because as students in the program, we don't really get that like personal information from like previous patients or patients who have experienced this and whatnot. And we only get the education, like textbook, this is how you treat it sort of thing. So again, thank you so much for meeting with us. It's been really beneficial for all of us. And I want to thank everybody else for joining today and asking questions and participating in this meeting. We really appreciate all these support. And from the entire NCODA board, we hope everybody has a wonderful day. And if anybody has any questions, is it okay, Becky, if we share your email and your information with the members who attended today's meeting?
Yeah, no, that would be great. Yeah,
absolutely. And then Maddie did record this meeting, and would you be okay with us posting it and sharing it with like the national NCODA student chapters to give them the opportunity to listen in on the webinar?
Yeah, I think that's fine. Yeah.
Awesome. Perfect. Okay, well, I'll share your info. And again, thank you so much. I hope everyone has a great weekend.